Welcome to Grand Rounds in Urology, Your Edge Learning Centers. I'm Diane Newman, urology nurse practitioner and the senior editorial director of Grand Rounds in Urology. I have invited Dr. Jason Hafron, who's the chief medical officer and medical director of clinical research at the Michigan Institute of Urology, Solaris Health. He's also a professor of urology at William Beaumont School of Medicine in Michigan. And I asked him to present the 2025 AUA SUFU Microhematuria Guideline because there's some really significant changes that I feel our audience would be interested in. Welcome.
Thank you so much, Dan, for the introduction and the opportunity to present on Grand Rounds in Urology. I agree this is an important topic. 6% of the U.S. population has microhematuria, and it is the most common referral to urologists today. So this update has some new changes that I'm going to highlight in the upcoming slides. And I think it's very important for urologists to understand this because, again, this is our number one referral in clinical urology today. With that being said, let's get started. Here is the guideline panel, as well as the amendment panel. The aim of this panel, and we want to thank the panel for putting this together from the AUA, that this is available on the AUA website or it's been published, but the aim was to offer suggestions for enhancing the diagnosis of microhematuria while adopting a more thoughtful approach to the evaluation, ensuring patients are not subjected to unnecessary tests. And what you'll see in the slides is that there's a primary emphasis on risk stratification. The AUA guidelines and their guideline committees have a pretty robust review process that gets pretty intricate and pretty scientific. But I think for this amendment, they basically had 23 articles that met criteria for qualitative analysis, and this is what formed the basis for this amendment. I think to understand this amendment, we have to look at the history of the guidelines. And the first guideline was published in 2012. And this was a little bit different than what we see today. But the first guideline was test everybody. Everybody got a cysto, everybody got a CTU or CT urogram. And the goal there was to minimize the likelihood of missing a cancer diagnosis. When you compare these recommendations, the AUA guidelines, to other society recommendations, this was the most intense. Also, it was the most expensive because everybody, again, got a cysto and a CTU. In 2012, they updated the guidelines and they introduced individualized risk stratification, which is a novel concept at the time. Instead of testing everybody, focusing on not missing any cancers, the focus was on testing appropriately or modifying the intensification of this testing. So it was kind of right test for right person kind of thought. And they divided the guidelines into three risk categories: low, intermediate, and high risk disease. And that was the 2020 microhematuria guideline. And the one that I'm going to talk about today is the 2025 amendment that just came out. And what they did was they refined the risk stratification. A couple key changes was they redefined low risk and now added low risk and negligible risk. I'll talk about that. And then they started to integrate urine markers for intermediate risk, which is very exciting, which is new and novel, and that's never been done in any of the previous amendments. So a lot to talk about. I'm going to try to break it down and simplify it so that clinicians can incorporate this into their everyday practice. Here's the guidelines. It looks like a lot. The guideline path hasn't really changed much from the previous. I think what I'll do is go into the details of the changes and the wording. Let's start with the first part of the guideline, the evaluation process of the patient. And you'll see that not any significant changes here, some little nuance changes that I'll just dig deeper into. I think what has been consistent since 2012 is that a urine dip is not adequate to define microhematuria. It has to be a UA with greater than 3 RBCs per high power field on microscopy. So the dip, that's nothing different. That's always been the definition of microhematuria. I think we see a little bit of changes with what's recommended in the history and physical exam. With the history, you should take a blood pressure, you should check a serum creatinine, and you should do an extensive smoking history. Also, what you should do is look for risk factors or identify risk factors in the patients that you're seeing for microhematuria. You can see the table below. The risk factors included in the AUA microhematuria stratification system, which we'll talk about, are age, male sex, smoking use, degree of microhematuria, persistence of microhematuria, and a history of gross hematuria. Additional risk factors for urothelial carcinoma are listed, and this isn't an exhaustive list. There's obviously more, but these are the top ones that you should consider is if they have irritative lower urinary tract symptoms, frequency, urgency, that's a risk factor for urothelial carcinoma, prior pelvic radiation, history of cyclophosphamide or isophosphamide chemotherapy, family history, do they have a history of Lynch syndrome, occupational exposures to benzene chemicals or aromatic amines, nothing new, and then chronic Foley. Those are the things that, when you're interviewing the patient, these are the things that you should ask and document to assess the risk. And then I think what has been highlighted in this, and I'll talk more about this, is that if a patient has a non-malignant or gynecologic source for the microhematuria, and it comes up a lot with women, do they have a UTI? Do they have an active gynecologic disease or issue going on? That you need to have that treated or evaluated. But I think what a common error is once that UTI is treated, you need to recheck that patient and make sure that once that problem has been addressed, that they still don't have microhematuria because that could be missed. You could present with a UTI, treat the UTI, and then they still have microhematuria. And I think it's important with women because when you look at bladder cancer, mortality, and overall survival, women do worse. So I think that is this the cause? We're not sure, but we know a delay in diagnosis of bladder cancer will impact survival and disease-specific mortality. So I think that we have to refocus on this area, especially with women, that a lot of times, oh, it's related to the UTI, we'll treat the UTI and blow it off. But in actuality, you need to bring them back. You need to, once that UTI is treated or once that gynecologic issue is treated, that they need to be reevaluated and make sure they don't have persistent microhematuria. Last is there's medical renal diseases for microhematuria. Sometimes this gets overlooked, but if a patient has persistent microhematuria from medical renal disease, those patients obviously should be referred to a nephrologist. So these are the kind of the subtle changes that were made in the guidelines. Foundationally, it's pretty similar to what we've seen before, but these are things, common sense things that we need to do on an everyday basis with this patient population because we see a ton of these patients. I think what really came out of these guidelines is that there were 3 studies that validated that were published between the 2020 update to the amendment that evaluated the initial guidelines. And what they wanted to do was to really see if the low intermediate risk was accurate. And what they found was, and this is a quick summary, is that generally speaking, low risk, intermediate, and high did separate the patients. But the problem is they found that 75% of the patients that had the 2020 risk categories, 75% of them were high risk. The other interesting thing is, and especially if you look at the Saxon article on the far right, which looked at women, is that women in the low risk category, the percentage of patients of low risk women having cancer was 0%. So, and then generally speaking, that when you looked at women, and I'll highlight in the risk stratification, is that women generally have, based on a low risk of harboring bladder cancer. So based on these studies, Waldo, CNC, and Saxon, this is what was the impetus for making the adjustment or the amendment that I'm going to go through. And most of the amendments that are key to understanding this are within the risk stratification based on these 3 articles. So if you look at the center of the algorithm, you can see risk stratification, and you can see that there were some adjustments made. I think, like I said in the previous slide, based on the Saxon et al. Article, is that they added this low negligible risk. So that it's not just low risk, there's a negligible risk of bladder cancer in microhematuria. What does that translate into clinical? Is that you can repeat the UA. Because there's such a low risk, especially in women, the repeat UA within 6 months is allowed. You don't have to immediately work them up. The other thing you'll see is that and I'll show you another slide, is that the criteria for risk was adjusted for women. And basically, women less than 60 are low risk, women greater than equal to 60 years old are intermediate risk. And then they took out women should not be categorized as high risk based on age alone. And again, that was that Waldo, Saxon, those previous 3 papers that led to this adjustment based on real world evidence. I think the other thing is, and we'll go into this, there were some adjustments made in the high risk category. And the other thing is that if a patient is previously low or negligible risk, and now they had a repeat evaluation that's positive, that makes that patient intermediate risk. So those are some of the highlights. I'm going to go into a little bit more detail about these, but I think most of the amendments are focused on this risk stratification or adjustment or tweaking of the risk stratifications to more accurately represent the risk. And here's kind of it looks like a lot, but it really breaks down what those changes are. So again, we talked about risk of malignancy. The changes you can see 25 compared to 2020 is we added that low negligible risk, and then they quantified that risk based on those papers. So if a patient is low or negligible, their risk of bladder cancer is 0 to 0.4%. Shockingly a low number and lower than I expected to see. Intermediate risk, we didn't change the nomenclature there, but their risk is 0.2 to 3.1%. And then the high-risk patient population, that varies from 1.3 to 6.3%. If you look at alternative criteria for degree of hematuria, I highlighted this on the previous slide, is that if a patient's low risk, you repeat their UA and it's positive, they can move into that intermediate risk category. We didn't have that. We've also added history of gross hematuria for the high risk as a criteria for risk. And then, well, like we talked about, we adjusted, or the AUA adjusted the risk for age of women. You can see that they broaden it or made it allow, for the low risk, they raised the ages. So low risk is less than 60, high risk is greater than equal to 60 years old for women. And then women should not be categorized as high risk solely based on age. Age for men didn't change, smoking history didn't change. And then some of the risk factors for 1 or more plus or any high risk feature was added to the high risk category. So these are the kind of a quick summary of the changes that were made. You can see there's just mainly risk adjustments to the stratification to better identify who needs to be worked up, who doesn't need to be worked up. I think the other cool thing that was added was the urinary markers. This is the first time that we've seen this in the Microhematuria Guideline. And I'm just going to read directly from the guideline. In appropriately counseled intermediate risk patients who want to avoid cystoscopy and accept the risk of foregoing direct visual inspection of the bladder urothelium, clinicians may offer urine cytology or validated urine-based tumor markers to facilitate the decision regarding utility of cystoscopy. Renal and bladder ultrasound should still be performed. So in intermediate risk patients who don't want to undergo a cystoscopy, you can offer them a urinary marker. Here's the table right out of the guidelines of the urinary markers that were evaluated. And you can see the table is CX bladder resolve, CX bladder triage, NMP22, urine cytology, Eurovision, and expert. And what you see, you can see the numbers. You can see is the NPV of these in this patient population for microhematuria. So again, if you have intermediate risk microhematuria, patients don't want a cystoscopy per the guideline, you can offer them one of these urinary markers, but you still got to do at least the ultrasound to make sure there's no upper tract disease. New and exciting, I think what I want to highlight is the CX bladder triage. CX bladder triage recently published the results of a randomized controlled trial, and this was the STRATA trial, which is also exciting because this was a randomized prospective trial that compared the use of CX bladder triage to standard of care evaluation, including cystoscopy and imaging in patients with microhematuria. On the left, you can see the trial design. Again, it's that comparison. If we forego cystoscopy and just do renal imaging, is that adequate to standard of care? Can we replace cystoscopy? And the results are very exciting and promising. And using CX bladder triage resulted in a 59% relative reduction in cystoscopy rates compared to the standard of care. It had an NPV of 99%. I mean, that's amazing. And then the sensitivity or the positive predictive value was 90%. So per the guidelines, per what we're seeing, is that this has the potential to reduce unnecessary cystoscopies, potentially can lead to unnecessary patient discomfort, anxiety, and the complications associated with invasive procedures. So an exciting first step to use biomarkers in the evaluation of microhematuria to avoid cystoscopy. Again, very limited, very well-defined guidelines in intermediate risk only in patients that do not want to go a cystoscopy. The other question that comes up a lot is in clinical practice, I worked up this patient, it's negative, now what do I do? I think the guidelines offered some clarity here to what to do with these patients. I mean, we can't follow these patients forever. So in 2025, they made a statement in patients with a negative risk-based hematuria evaluations, clinicians should engage in shared decision-making regarding whether to repeat urinalysis in the future. So it kind of puts the ball in the patient and the physician's court, what to do if they want to continue, as opposed to where it was in 2020, was that you should repeat the urinalysis in 12 months. So that's kind of left it up to the patient and the urologist. So the key takeaways here are the 2025 amendment incorporate better risk stratification. They rename low risk to low negligible, and they support the use of a repeat UA within 6 months. And in the absence of high-risk features, women should not be classified as high risk based on age. And also the other key takeaway is urinary bladder tumor markers or cytology may be used for intermediate patients that want to avoid cystoscopy. Thank you so much for this opportunity to present to you on grand rounds in urology.
Thanks so much, Dr. Hafron, for this, because you're right. It really has clarified exactly what we should do with that initial patient coming in, depending on where their risk stratification is. My concern, though, is a lot of times adoption. I'm really want to thank you for presenting this, because we do have a good audience in urology, urologists as well as advanced practice provider. But what do you think about? Do you think this will be adopted? Because, we right away go to cystoscopy on these individuals. And, that's kind of like what our care pathway has been. And I really worry about the fact that, is that something that we're going to be able to change that kind of, behavior?
Yeah, I think it will over time. Like this is a good amendment. I think it's more in line with the real world data, so that we appropriately cysto. The repeat urinalysis and the low risk or the negligible risk is totally allowed. And I think if we look, I think this is more aligned with the practices or the patients we're seeing every day. I mean, if you look at 2012, where everybody got a cysto and a CTU, that was overkill. Now we can address it or fine tune or better stratify the patients to what they actually need. So I think it will be well received. But you're right, to change physician behavior and process does take time. But I think education, understanding the numbers behind this are really critical. Like when you see that the low risk patient has a 0% chance or less than 1% chance of having bladder cancer, I mean, I think we got to be realistic with where we should spend our time and resources.
Well, the other thing, though, too, is that primary care could do the urine testing, right? as opposed to right away referring over to urology. And that's something that really could happen in practice.
Yeah, I get concerned though when you shift, to primary care. I think that they don't have the same focus. I think the risk assessment does, you have to do the risk of cancer. I don't think they have that breadth of knowledge or that focus. So I would still, say that this evaluation has to be done by a urologist or an APP, wherever you are, because they have that understanding of bladder cancer and the risk associated with it. I just worry that a lot's going to be missed or a lot's going to be avoided. And does a primary care doctor really want to take on that risk of missing a bladder cancer? Yeah, it's low, but we know if you miss one, that can, affect someone's, life.
Well, and like I'm glad you brought up about women, because women do come in with a lot of other reasons why they may have microhematuria. And I like the fact of you saying, and what they say is that please read once maybe the underlying problem. It could be UTI, it could be a gynecological like genital urinary syndrome and menopause, which actually the AUA has new guidelines on that. It could be something like that. But once that's managed or treated, if that microhematuria persists, they really need to be evaluated.
Yeah, definitely. And I think, I can't make the connection or I don't see a connection in the literature, but, women do worse with bladder cancer, and that's something, the they don't live as long, they have a higher recurrence rate. So there may be, I think, whether the physician gets distracted with other issues, you gotta recheck them and make sure that they don't have they don't have true microhematuria and not related to the UTI. So I think that it's a good area to focus in.
Yeah, and I mean, we're really excited about you recording this for us because we do go to YouTube, and that's where actually a lot of individuals, right, read, professionals do, but also patients. So we need to educate patients about this because they need to be their own advocate for what their symptoms are. So I really appreciate you doing this.
Definitely, my pleasure.